This is the last video in our sensory processing series, so to say, so part 3 of 3, and this is where we're going to give you some actual hands-on strategies that you can apply in a clinic setting when you're working with patients. So we've already talked about the idea of a seeker and avoider and what that might look like in your different patients. So now we're going to get into the actual sensory modalities. Technically, there is a CPT code for a treatment called sensory integration training. It's 97533. Typically, this CPT code is performed by occupational therapists, but I suppose it could be performed by physical therapists. I will say this, it is not reimbursed by Idaho Medicaid or any state's Medicaid that I have been able to find. And it's also not reimbursed by pretty much any insurance payers. So there's reasons for this. One is it's considered to be an experimental treatment approach. And like I mentioned earlier, the research surrounding sensory integration training is a little bit vague. The criteria isn't very well defined. And there might be some evidence to suggest that these sensory issues kind of solve themselves. So it is not a standalone intervention that you could bill for. You can't just do sensory integration. So when we say that we're doing, and I'll hide my face here so you can see this full slide. When I say I'm using a sensory approach to my treatment, I'm using the idea of these sensory constructs to be able to improve patient participation. So that's different from sensory integration training, which is isolated focus on the sensory inputs and changing that response. If I'm using a sensory approach to therapy, then what I'm doing is I am using motivations or responses or different strategies to improve my patient's participation in a motor based activity. So we're working towards movement based goals, and I can use some tricks, so to say, to improve their participation. So that's the kind of tips I'm going to be giving you. Is not sensory integration training. This is just some sensory tricks, some uh, processes, approaches, systems, for lack of a better term, that you can use to improve patient participation, especially when working with children. So I have found that this is very useful when working with kids, especially kids that show signs of maybe a sensory variance or a sensory processing disorder. That's not just kids with autism. So like I mentioned in our second video, I myself tend to be a sensory seeker. My kids are sensory seekers. None of us are diagnosed with autism spectrum disorder, but we have this tendency towards seeking proprioceptive input. Um, I will also note in my experience that children with intellectual disabilities also respond well to these techniques because they can be motivating, and in lots of ways you can use them to promote a fun treatment environment. So again, I'll emphasize this is simply a way to supplement your motor-based goals. These are movement strategies or treatment strategies to improve participation, to either arouse or calm a child, depending on what you need. And you could even use some of this approach as a reward as appropriate in your treatment strategy. So the idea of a sensory-based approach to treatment is finding a regulating activity. So this is where you calm the overstimulated and arouse those seeking input. Basically, it's a way to help you desensitize avoiders or satisfy seekers. And hopefully you can tell just in the way that I'm talking about this, there's a reason that this isn't reimbursed because it's kind of vague. So if you're like, what is this guy talking about? I understand. That is how I felt the first time this was introduced to me. Because sometimes the same activity can be calming and sometimes it's arousing. And that still doesn't make a lot of sense to me. What I have found in a kind of a practical way is that many of these strategies are effective for improving behavior and participation. And so that's why I use them. And that's why we felt it would be appropriate to include in your didactic education, because we're going to give you information about conditions, but we have to give you strategies to be successful in the real world. And so that's what today is a little bit of a taste of. So there are different approaches for each of the senses. We're going to go through each of the senses and define what could be calming, what could be arousing for each of those. And then we'll kind of focus and spend the most time on the category of proprioceptive activities, because there's a category called heavy work that's he's the superstar, right? He calms, he arouses. It's kind of the catch-all strategy. So we'll describe what that could look like in a little bit more detail as we go through those senses. And then after we do that, I have a couple of cases that we'll present and let you think about maybe what would you do in the situation and how could you use some of these strategies to improve the participation of that child. So we're going to stick to those senses on the second video that had either 1 or 2 asterisks by them, because we can either modify the environment, and I have it noted when there's an environmental adaptation versus when it's like an actual treatment or activity approach. So visual, and the next slide has auditory. These are environmental adaptations that you can do with a patient. So if you need to stimulate someone, if they seem to be sleepy or they have low arousal, if you want to stimulate them, then you can use bright colors, bright lights, busy backgrounds to get their attention and maybe catch their focus if they're real kind of sleepy dumpy. If they're super, all over the place, or they're seeking and they're just looking, and you can't bring them down, then you would want to do the opposite, right? You'd want to go to a space where the colors are more neutral, where the lighting is softer and the background is less appealing. So in the case example, not the case example, but just the example I used earlier of the patient who did not like the way our rock wall looked, it kind of made him woozy. He was overstimulated. And so that was in a case where he didn't need to be calmed. He actually was overstimulated. So we had to move to a different part of the clinic where it was a little bit more neutral and soft and had a quieter background. And he responded really well to that. Eventually, we were able to gradually progress the nature of his environment. Then we'd like cover part of the wall at the bottom that was at his eye level. And eventually we were able to get rid of those covers. He was able to function in the entire clinic, and that was really helpful for him. But we had to keep that in mind because he was so distracted at the start by that rock wall, he wouldn't do anything else for us. So in the auditory sense, we can make some environmental adaptations as well. Again, if we want to stimulate someone or we want to arouse them, we can use music with a fast and distinct beat. You can use asymmetrical beats. So that's where it's not just like 1, 2, 3, 4. Maybe it's like 1, 2, 3, 1, 2, 1, 2, 3, 1, 2, 1, 2, 3, 1, 2. That is going to be more attention grabbing than something that's just a consistent drum. In the world of music, there's something called a timbre, and that's how it sounds. And so when I have brass timbre here on the slide, brass timbre is referring to like brass instruments. So trumpets or trombones or horns, things that are kind of loud and in your face. Those are excitatory, so to say. Versus if we have someone who is dysregulated, or they're way overdone, maybe they're overstimulated, or they're seeking so much that we can't keep their interest. If we want to do that, we could do the flip side. We could do some calming stimulus, and we could do slow melodious music. We don't want an emphasized beat. We want an emphasized song, for lack of a better term. And then a string timbre would be like the sounds of violins or cellos, or even an acoustic guitar, not an electric guitar. Those kinds of things can be stimulating or calming depending on your needs. So I will say, as I'm describing these things, calming isn't always for seekers, and calming isn't always for avoiders. Stimulating isn't always for one or the other either. So we talked previously about the difference between a seeker and an avoider, but that doesn't mean you're always going to use the same strategy for each. It really depends on how that patient presents, what their presentation is uh, preventing them from doing, or how that affects their participation or activities or things like that, and then adjusting your approach. Sometimes seekers, in seeking for one sense, maybe overstimulate themselves in other senses, or they are searching so much that we have to do something stimulating to catch their interest, versus, an avoider might be so avoidant that they're actually sleeping, we have to stimulate them, or they're so overstimulated that we have to calm them. So you may use a stimulating or a calming strategy with a seeker or an avoider. It just depends on how they present. So typically, if I find a kid that's crying, they seem to be um, undone, and they don't have a lot of control of themselves, that's either um, a seeker that doesn't have what they want, or an avoider that's overstimulated. And I'm probably going to do something more in the realm of calming. If I have an avoider that isn't crying, but they're not engaging, I might do some very gentle stimulating activities. Or if I have a seeker that, you know, they're not too crazy, but I can tell that they're kind of chomping at the bit to do something, I'm going to do some stimulating activities that are directed towards what it is I want that person to accomplish. So hopefully that starts to kind of create a picture of how you can use this in treatment. So we've been talking about environmental adaptation. Let's talk about the actual things you can do with the patient in your treatment. So if I needed to provide stimulating input for someone, they were seeking, or I was trying to arouse them, I might have them stand on things like spiky balls, or something that was a little prickly, not painful, but maybe a little prickly. Maybe we'll go outside without shoes on. Maybe we'll find something with a gooey texture or a slimy texture, or maybe we'll do something that's hot or cold, because those kinds of things can grab attention and can be utilized effectively. Versus if I need to come with the calming approach, I'm going to search for neutral warmth. And one way to get that is with a very light compression. So that could be with the garments that the child is wearing. If they have just like a very kind of lightly stretchy spandexy fabric that's not too tight, that can provide neutral warmth. Or our clinic had just little stretchy vests, neoprene vests, that I'd strap on the kid to give them that squeeze, but it also provides a sense of neutral warmth. Soft fabrics or smooth surfaces are also calming if I need to bring a child back to my level. And again, remember, I might need to calm the seeker or the avoider depending on where they're at. So let's spend a little bit more time talking about proprioceptive strategies for sensory issues. So proprioceptive is the catch-all category because most proprioceptive activities that we might do in a sensory-based approach are considered heavy work. Heavy work is where you do something that's challenging. It's exactly what it says. It's work, it's kind of hard, it's not too challenging, but it's a struggle, just a little bit of a struggle for the patient. These can have a calming or a stimulating effect on a patient. And this is generally what I would fall back on as a physical therapist, because so many of these activities were conducive to the goals that we were working on. So some practical examples of proprioceptive heavy work activities are push-ups, sled pushes, a heavy leg press, maybe bike riding with resistance. Um, Sometimes I would provide the resistance for a leg press for some of my littles. I'd have them lie down and I'd put their feet right on my chest and I'd have them push. I just have them push as hard as they could, and I would just respond enough to kind of move. I mean, I had to move myself because they're not strong enough to lift my torso, but I would let them work as hard as they could. And sometimes if they were just all over the place and we could get a couple of those in, all of a sudden they would focus better on the activity at hand. And then we could try it again. And if we lose focus, we'd do a couple more of those leg presses, and then we'd go back to the activity that they were struggling to attend to. So I love the heavy work approach because it's so practical. And then if I was doing that heavy leg work, leg press, well, that's also quad strengthening. It's just kind of like doing a squat in a different position. And so you can think about if you're working towards a goal and the child's not attending, well, maybe just like break it down really fast, have them do something really hard that's realistic for them, but challenging, that's in line with your goal, and then go back to the specific activity that you're working on. I found it was a very effective strategy when working with kids that were dysregulated. So vestibular activities can also be used. I'm going to describe some of these with a word of caution. Vestibular inputs tend to linger. So if I'm trying to arouse a child and maybe I over arouse them, that's going to last a little bit longer if I did it in a vestibular sense than if I did it with another sense. And the same thing with calming. So I've had a couple kiddos that have been overdone. We've calmed in a vestibular mode and they've fallen right asleep. And so vestibular inputs can be really powerful, but they can linger. So hopefully a lot of this makes sense, right? If you're trying to stimulate someone's vestibular system, you're going to do fast spinning motions or fast back and forth, fast up and down. That's going to get that system to activate in all kinds of directions, and it will be stimulating to them. Also, if you're erratic, so if you're moving kind of here and there and you don't really have a specific pattern, that can be really stimulating. Versus if you do a slow, rhythmic, rocking motion, sitting on firm surfaces, those are kind of grounding and very calming. So kind of a slow swing if a child's been a little grumpy and they seem like they need to be calmed a little. Well, I've done slow swinging and that they'll just fall right asleep on the swing sometimes, which may or may not be helpful. So use this category wisely. So let's think about these strategies in terms of a case example. I'll describe the case, give you a little bit more context on what's on the slide. Then I want you to pause the video and I want you to think about which of these strategies, even go back through the slides and think about what could you do. So this is a 2-year-old boy. He doesn't have a clear diagnosis. He's quite sedentary, especially compared to other children his age. You note that he has poor head and core control. He would prefer to sit on his mom's lap and doesn't really have a lot of interest in doing much else. He is able to walk, he can throw, but he's not, catching or really making efforts to catch. He's not going up and down stairs very well, pretty fearful around the stairs. Definitely isn't running and shows no interest in jumping. So he's terrified of anything that is not a hard surface. So even just like an Airex or a foam pad really makes him upset. Don't even mention a Bosu ball. So when you have done some work with him, you'll find that occasionally he'll just cling onto you as a therapist, just press himself into you. So my questions are, does this child show tendencies that would indicate he is a seeker or an avoider? My second question is, what kind of strategies would you use to facilitate this child's participation in your treatments? He's showing signs of gross motor delays. How are you going to facilitate his improvement? And are there any sensory strategies that we've discussed that you feel like might apply to him? Take a minute, pause the video, and think about that. Jot down a few notes if you think it will help you. Just so you know, this is based on a real patient that I have worked with. So case example 2, a little bit of a contrast. This is a 6-year-old girl. You know that she does not have a diagnosis of autism. She's working on catching a ball with hands. She is very distracted. She struggles to listen. Mom reports that she's always running and crashing into things. You notice she's really fidgety. She's a really fast runner. She loves to jump. She climbs a rock wall pretty well. She does lots of things pretty well, but she's struggling to catch a ball. So here's the questions. And pause the video if it will be helpful to think about these. Is she a sensory seeker or an avoider? What would you do to facilitate the goal of working towards catching a ball with this girl? So just a little background. This is actually a description of my daughter several years ago. So kind of giving this away at this point. This is supposed to kind of typify a sensory seeker. And the other case was supposed to describe more of an avoider profile. On the next slide, there's a little video that shows maybe the difference between a slight avoider, typical sensory child versus a seeker child, who is my daughter. So hopefully you get a kick out of that, but hopefully it's insightful as well.
Here's a fashion show. Lindy's first. Oh. Do your poses. Ooh. Beautiful. Beautiful. Go off there and back. Oh, yeah. Beautiful. Okay, Ivy, your turn. Fashion show. Is that your fashion show?
How did you do your poses? I did.
Do your poses. Poses together.
Okay, I'll do my pose. You do your walking.
No, just poses. A pose is where you hold still and make a pose. That's your pose? What's your pose? You girls are cute.
Hopefully you could see a little bit of the difference between at least a seeker and a non-seeker in that video. So just some final thoughts on sensory approaches to physical therapy treatment. They can be a really positive supplement when you're working with a child, especially if they show a profile that's not typical. Some kids aren't, whether it runs in families or not, and the jury's kind of out on that. But you will likely, if you work with kids in any capacity, you'll likely run into kids that show some kind of either a seeking pattern or an avoiding pattern. And so knowing how to recognize and then adapt to that will be helpful. I want to emphasize again, sensory integration therapy should not be performed as a standalone intervention, especially by a physical therapist. It should be used in the context of a more global treatment, especially in working towards specific movement-based goals. Make sure that you apply the approaches specifically to the child, because even a kid that shows more of a seeking tendency might avoid certain sensory activities. Be very careful with vestibular inputs because they can be super powerful and they can last a long time. And then kind of the rule of thumb from all of this is, when in doubt, find a heavy work activity that's appropriate for the child and in line with your goals, and you're going to be right 90% of the time, because it can have an arousing or a calming effect as you need. Make sure that it's fun. As long as it's fun and you get that heavy, kind of challenging but satisfying element to it, the child's most likely going to respond really well, and you'll facilitate progress towards your goals. So, if you have any further questions about a sensory approach to physical therapy treatments, feel free to reach out to me personally. We can either set up time in my office hours or we can answer things over email. I have found that this strategy has been helpful. I've primarily used it with kids, and occasionally I have used it with adults, with success in facilitating participation in treatment sessions and working towards goals. So, if you don't have any questions, you don't want to reach out, I know you don't have any for me right now because you're watching a video, but if you do have questions, make sure to reach out, and good luck with everything you're working on the rest of this semester. Here's the references for the presentation. It's from the training I received at Primary Children's Hospital, as well as sensoryprocessingdisorder.com.